Hello, welcome to the Geriatric Health Lecture Series. My name is Barbara Cochran. I'm the director of the Deterney Center for Healthy Aging here in the School of Nursing. Today I'm representing the Northwest Geriatric Education Center, which is the sponsor of this lecture series. And we are broadcasting throughout the Northwest region and parts beyond. So welcome. I'm really pleased today to introduce one of my favorite people, Dr. Elizabeth Phelan. She is the Assistant Director for Evaluation of the Northwest Geriatric Education Center, and she oversees the evaluation of our center's educational programs. She's also an Associate Professor in the UW Division of Gerontology and Geriatric Medicine, and an Adjunct Associate Professor of Health Services in the Public Health School. She is also an affiliate investigator with Group Health Research Institute and co-director of the UW Center for Interdisciplinary Geriatric Research and founder and director of the Fall Prevention Clinic at Harborview Medical Center, which she founded in 2005. She's clinically active, I can vouch for that, fellowship-trained geriatrician whose clinical work encompasses the inpatient and outpatient settings and involves teaching principles of internal medicine and geriatric medicine to students, residents, and fellows. Her research aims are to promote health and prevent functional decline in community-dwelling older adults. And today, Elizabeth is going to talk to you about risks of hospitalization for older adults. Welcome.
Thank you very much. Thank you. And I will be happy to share what I've gleaned from experience and also from looking into the literature a little bit about this topic of hospitalization in older adults. A lot of the shape of this talk is out of clinical experience, and I do, as Barbara mentioned, a lot of work in the hospital consulting for older patients who have been admitted oftentimes for injuries, and so have see a lot of what I'm going to talk about on a regular basis. So I'm going to start with a case, and actually this is as you'll see, a very illustrative case that encapsulates what oftentimes happens in an older adult who gets hospitalized. So this is a 92-year-old woman who has several chronic conditions, and I'll go over the abbreviations. This is diabetes, high blood pressure, high cholesterol, and chronic kidney disease. Very typical for older people to have several, if not multiple, medical problems by the time they get to be 90 in particular. And she came to the emergency room complaining of shortness of breath and some suggestion that she might have been having some ongoing chest pain for a number of days and complaints of weakness. In the emergency room, she was found to be short of breath, tachypnic, diaphoretic, meaning very sweaty, with a high blood pressure, with abnormal lung sounds pretty much throughout her entire lung field, and looked like she had excess fluid volume, what we call volume overload. And her lab tests also indicated that, as did her chest x-ray. There was also potentially a suggestion of pneumonia on the chest x-ray. Her cardiogram showed some concerning changes potentially for heart ischemia or blood flow compromise. What happened to her in the emergency room is summarized here. Her blood pressure was emergently treated and lowered quite substantially from that very high reading initially down to 115/85. She was actually sent for an emergent cardiac catheterization, so looking at the heart arteries because of these concerning changes on her EKG. She was actually found to not have any significant narrowing in her heart arteries. She then underwent a specialized study to see if she had had a clot that went to her lungs called a pulmonary embolus. And she was actually found to have a clot, and so was begun on a blood thinner, heparin. While she was in the emergency room, she vomited, and there was what appeared to be potentially some bleeding in her upper intestine in that vomit. And so she underwent a consultation by the intestinal specialist who said she needs evaluation with an upper endoscopy and a lower endoscopy. She had a cardiac echocardiogram to assess her heart function, which looked like it was not horrible, not quite normal, but really not too bad. She had evaluation of her legs to see if there was any sign of clot that could have been the source of the clot to her lungs. That was negative. And then she had a pulmonary specialist see her, and they said, well, that study of the clot in the lungs was a false positive, that she really doesn't have a clot on further review. She was admitted to the hospital, and over the course of her hospitalization, her kidney function deteriorated substantially. She stopped making much urine. She developed a complication from that cardiac catheterization that she'd had, which is this fistula and lesion in her artery, where she was evaluated with the catheter insertion. This was treated with some more blood thinning locally, but then that spot became infected. She required multiple antibiotics to try to treat that infection. She believed it all through all that. She was resilient and persisted to live. But unfortunately, on the day of discharge, she was ready to discharge and fell. She then underwent, because of a clot in her brain, she underwent emergent burr hole, meaning just surgically creating a hole in the skull to drain that blood. But she didn't ever recover from that. Her kidney function, her neurologic function further deteriorated, and she was placed on comfort care and expired ultimately. So this is a very dramatic case, but these kinds of things are the things I'm here to talk with you about today. And these are the objectives. So I'd like to increase everybody's awareness of the risks of hospitalization for older people. And to describe a little bit so that we understand why older people are more susceptible to hospitalization and the things that come with being hospitalized compared to younger people. And then to focus really on, well, what can we do? Really, prevention, the saying an ounce of prevention is worth a pound of cure is very true in this setting, and I'll carry that idea forward in giving you some examples of what we know about how we might prevent some of these things, untoward things from happening to people if they do have to be hospitalized. So here I've listed just a lot of things that can contribute to complications and put older adults at risk if they're hospitalized. Simple things that we take for granted, giving people IV fluids, intravenous fluids, undergoing procedures, as this case illustrates. There's a risk to every procedure, and oftentimes the risk isn't necessarily weighed in people's minds, I would say, quite as heavily as the potential need to do diagnostic procedures. Placing catheters in people's bladders, putting other kinds of tethers on them that may be part of their acute care, but make them immobile, and maybe because they're sick, they're not able to eat, and in the rush to look for diagnostic entities that can be treated, people's nutrition may not be attended to. So all of these things are what I call hazards of hospitalization for an older person. So why are older adults so at risk for complications in the hospital? This is in large part due to what we refer to as normal changes that are associated with aging. And there are several aspects to this, and I have those on the slide. First is that what we call the therapeutic window, meaning where benefit is achieved and risk is averted, that treatment window of opportunity really becomes much smaller. So we're really balancing risks of treatment and risks of harm in much closer harmony. Also, older adults, due to aging, have less of an ability to mount responses, a stress response. And also, environment becomes much more influential in terms of how they maintain homeostasis. So when, for example, we try to move in a new environment, we take that for granted. For an older adult who may be very accustomed to moving within their own home, they have certain props they may use to hold on if their balance is poor. That becomes much more, that environmental dependency and interaction with the environment becomes much more of a factor. And then lastly, at the organ system level, there is what we call diminished reserve. So as an example, due to, again, normal aging, blood flow to the kidneys is diminished, and what we call glomerular filtration rate, or filtering of substances through the functional structures of the kidney is decreased. So, for example, any drugs that are processed through the kidney may persist and the effects remain for longer. So, how would we gauge whether or not this is an issue for all older adults or every patient that we're seeing who's hospitalized? Or, what do we know about who might be most susceptible to the risks of hospitalization? So, people have looked at this. This is not a recent study, but it's a well-done study that sheds some insights into what are the markers of a person that would tell you they may be more likely to undergo or have a complication when they're hospitalized. A key point here is that, and there's several things here, but atypical presentations may be a good marker of people who are at particular risk for complication. What do I mean by atypical presentations? I give a couple of examples here. So one is a person who is older and actually has a new pneumonia. They may not have the classic symptoms of an older person, of a younger person who has pneumonia. So, for example, a younger person with pneumonia usually they develop a fever, they develop a cough, they may develop oftentimes increased phlegm or new phlegm production. For an older person, by contrast, they may not have any of those signs or symptoms. They may just fall, and they get evaluated, and lo and behold, probably the reason they fell was they had a pneumonia. As another example, classic presentation for a younger person with a heart attack, a myocardial infarction, which I've abbreviated here as MI. A classic presentation would be crushing chest pain and or sweatiness, that diaphoresis, potentially nausea and vomiting. By contrast, an older person might just present with a new confusional state that we call delirium. So these are examples of atypical presentations. These types of presentations, these atypical presentations, suggest or a marker in turn of frailty. And frailty, atypical presentations, as well as a few other factors that I've listed here, were shown in the study by Jarrett et al. To predict adverse outcomes from a hospitalization. And some of those adverse outcomes, it doesn't have to be death like our case, but it could just be the person ended up staying in the hospital much longer than you would expect. Or they, instead of getting discharged to home where they lived before, they end up going to a skilled nursing facility because they're not able to, they haven't recovered enough function to return home directly. Some of these other factors here, though, I think are important, and we don't necessarily always elicit these things in our admission history. So something to think about. One is what we call premorbid functional status. So what was this person doing for him or herself before they got sick, i.e. premorbid? and also functional decline at admission. So did they have an acute decline in their ability to function, i.e. take care of themselves, do their daily activities, self-care, and maybe other activities at home like cooking and so forth, just within that window of time when they may have been becoming sick. And those are pieces of history that we have to get, usually from family, especially if the older adult may not present alert. So family or anybody who knows that person and can provide that history are often important at initial evaluation of an older adult coming into the hospital. And those are things that, as I said, can help us say, I need to raise my index of suspicion here. This person is somebody who I need to be very careful about how I manage in the hospital. Not that we're not careful, but we need to have a high index of suspicion that complications may arise. Okay, so there were lots of hazards that I showed you a couple minutes ago on the slide of the myriads of types of things that can adversely affect an older adult in the hospital. I tried to pick a few topics just to kind of focus attention on things that we can potentially prevent from happening, and also that are specific to the elderly population. So I'll talk a little bit about each of these in turn. First, the risk of medical intervention, then acute functional decline that occurs in the hospital, delirium, and lastly, falls. So that first topic, what I call risks of medical interventions. And the case really, I think, that I started with just shows the risk of medical intervention. So meaning diagnostic tests, diagnostic workup, and treatment for things that are found on those diagnostic tests. There's actually a term that was coined in the literature for this, and it's Cascade iatrogenesis. And what that implies is, as it's defined here, a related sequence of adverse events triggered by an initial medical intervention. Iatrogenesis means things that were caused by care, treatment. And the cascade is that series of events. So essentially, first one thing happens, and then another thing happens. And again, the people who coined this term and first described this phenomenon, similar to the study that I showed you just a minute or two ago, tried to understand, well, who's at risk for this? What are characteristics or markers of people who come into the hospital and are susceptible to this cascade iatrogenesis? And these are people who are in the oldest old age group. So in geriatrics, we think about the older adult population as being further subdivided into young old, old, and old. You may be familiar with that, but when we talk about the oldest old, we're talking about 85 and up typically. Another marker of a person who would be at risk for this kind of cascade iatrogenesis, so-called, is people who are already functionally impaired. So somebody who, for example, is receiving home care services, a chore worker who helps them do their household chores, for example, may also help them with some bathing, potentially. That's, again, something that you find out usually by history. And then the other factor or marker of people who are susceptible to this are people who are quite sick at admission. And these researchers who described this phenomenon actually did find that this might be averted, this kind of complications cascade, if closer assessment at the initial evaluation to functionality was being done. So bottom line, and what I think is important to take home from this is, as part of a team approach, I think it's helpful for people who are involved in a patient's initial care to be thinking about each suggested procedure, test, intervention, and say, how important is this? And actually, do we need this test right now? In medical practice, in particular, we tend to start a workup, and there's a lot of sort of workup that's diagnostically driven, algorithmically driven, and sometimes we need to stop and think, do we really need that test at this point? Because every potential test is a complication waiting to happen in this older population. Okay. So acute functional decline, and I'm going to describe two aspects of functional decline, and acute refers to acute meaning during the hospital stay. So in other words, this is a result of the hospitalization. The first is around mobility, walking. So in some other work I'm doing right now, looking at older adults' values around mobility. And what we're finding is pretty, we would think is probably pretty obvious. Older adults really do value their mobility. Being able to ambulate independently is really important to most people. And I think it's telling that this study by Dr. Mahoney, again, a number of years ago, examining the prevalence or the incidence, meaning the new development of walking dependency, meaning the person was able to walk prior to being admitted to the hospital and left being unable. This was actually a not too uncommon phenomenon. This was a study of people over the age of 70, and almost 20% were newly dependent in walking at discharge. And then of those, actually about a quarter, a little bit more than a quarter, remain dependent, still 3 months out. Looking at this set of risk factors or things that made it more likely in this sample that she studied to have this adverse occurrence as a result of hospitalization. Some of this stuff is starting to sound really familiar. These people were the oldest old. They were chronically ill. They had a number of comorbidities. They were using an assistive device prior to admission. Again, a form of functional dependency. And they were more likely to have impairments in what we call either instrumental activities of daily living, or IADLs, or basic ADLs, or self-care. So things like bathing, grooming, and dressing. And this study really came home to me because my husband's aunt experienced this, and she has passed away, but she had actually underlying inflammatory bowel disease for many years. She was a smoker, so had some lung disease, and she developed problems with her kidneys and was in and out of the hospital multiple times. But the first time she went into the hospital with kidney failure, she actually came out no longer able to walk. She actually was walking and was living in her own home, left the hospital unable to walk, and went to a skilled nursing facility and remained in that skilled nursing facility for the rest of her life. So you will probably encounter this in your practice, and it's highly unfortunate. The other aspect of acute functional decline is new dependency in basic self-care, or activities of daily living function, ADL, abbreviated here. This was a study by Kavinsky and colleagues at UCSF, and they looked at a large cohort of people, again, over the age of 70, who were hospitalized, and asked them about how was their self-care at the time of admission and again at discharge. And they did find that about a third of people had worse function at discharge than prior to their illness, prior to being hospitalized. And they looked to see, again, factors that made it more likely for this new dependency in self-care to develop as the result of this hospital stay. And again, age, advanced age, was the strong, really the significant factor that they found. And again, that oldest old in their study, it was people who were at least 90 or more. So, recurrent theme, even just age, if you want to think about this topic in a very simple sort of take-home message, so far what we're seeing as a theme across these studies is that just age alone is a very strong predictor of hazards of hospitalization or complications. There's actually an instrument called the HARP, Hospital Admission Risk Profile, that looks at, is a tool. In geriatrics, we love tools. We love screening tools and instruments. And this was a tool that was developed and shown to, and validated to help identify people who are at risk for functional decline specifically. And that recurrent theme again of age, dependency in functioning prior to admission, and then in this, the cognitive dysfunction also is part of the risk profile. So certainly these other studies that haven't looked at cognition may or may not have been able to do that, but this is an important, I think, factor to take into consideration as well, based on this instrument that has shown it to be a factor. And this is I wouldn't say it's a really commonly used instrument, but it's out there if people want to use that. Or again, thinking simply about functional decline, taking that history about premorbid functionality, as well as just triggering, the age should trigger it for us as well. And there has been some research on how to prevent this phenomenon from occurring. And I'm citing a couple of studies here. One is what I would call a classic at this point, geriatric landmark study on what's called acute care for elderly units, or ACE units for short, led by Dr. Landefeld and colleagues, published in the New England Journal. And this other study is more of a synthetic synthesis of the literature, looking at across studies that have tried to intervene to prevent this kind of functional decline. So what I think the take-home message here is that that we can do some things to reduce the chances of this kind of functional decline occurring for older people. The ACE unit model, which is not prevalent everywhere, but is certainly found in various healthcare facilities throughout the country these days, really emphasized early physical and occupational therapy, early mobility. So as soon as that person, and oftentimes it requires pushing, encouragement. I have patients who tell me that the physical therapist is just needling them to get up, and I'm like, good, that's good. And I explain to them at that point why that's good. And even when they're not feeling too well and feel like they might not want to engage, that this has benefits. And attention to nutrition. So again, that kind of holistic, functional and holistic intervention approach. And the effects that in this meta-analysis, as well as in the ACE unit study published in the New England Journal, are shown here. So people who were intervened upon in this multi-component approach were more likely to go home, more likely to be able to perform their ADLs independently at discharge, and they actually had a little bit shorter length of stay in the hospital, and costs, therefore, were somewhat reduced. So bottom line out of this, and if you practice with an older adult population or you're in a field that focuses on function, this will seem obvious to you, but I can tell you that assessment of functional status is not routinely done, and it's important enough for this age group that I suggest that it be a vital sign. Just like every day we check older adults' blood pressure and heart rate, somebody should be monitoring their function and trying to maintain and prevent decrements during the hospital stay. And this kind of preventive, preemptive rehabilitative strategy is particularly important for our oldest old in the hospital. Delirium. What do we mean by delirium? Just so we're all on the same page. Delirium is an acute confusional state. And it's different from depression, which is a mood disorder. It's different from dementia, which is a memory disorder. But it's something that we see kind of oftentimes these 3Ds can coexist, run together, and one may increase the risk of the other. But at any rate, it's an acute state that develops with a sudden onset, and it's one of the hallmarks, in addition to being an acute event, is that it has what we call a fluctuating course, meaning that even within a short period of time, over minutes to hours, it can seem to improve and then worsen once it becomes established. The other hallmark of delirium is that of inattention. So instead of a person being able to engage with you in a what seems to be a normal conversation, they may be seeming like they're ignoring you. They may look like they're asleep. Or they may be talking about something that completely is unrelated to anything that you might be trying to cover with them in your interview. Thinking is often disorganized, and level of consciousness can range from essentially obtunded, meaning non-responsive except to harsh stimuli, to hypervigilant or hyperactive, where people are very agitated, trying to climb out of bed, striking out at staff, biting, etc. What do we know about risk factors for this condition? I alluded to dementia just a minute or two ago. Age is certainly a risk factor. Cognitive or dysfunction or memory disorders, anything that's affected the brain adversely, like sort of structural damage due to stroke. Again, functional status, so people who are functionally impaired are at risk for delirium. People who have sensory deficits, so they either have trouble seeing or hearing or both, are at risk for delirium. If they're poorly nourished or dehydrated, they're at risk. Medications can contribute to delirium, and comorbidities, meaning lots of chronic conditions, put people more at risk for delirium. A little bit more about medications. There are some medications that we worry in particular about and try to avoid actually using in older adults because they have been shown over and over again to be associated with precipitation of delirium. And some of those are listed here as examples, but for the most part, the unifying, regardless of the name or the class of medication, is that the side effect profile is one in which there are what we call anticholinergic side effects. And one of those is on the cholinergic centers in the brain. Benzodiazepines is the other class. Those are drugs like Valium, Ativan, etc. And those drugs, again, have a strong association with precipitating delirium. We really reserve those in an older adult for treatment of alcohol withdrawal for that reason. Why do we care about delirium? You know, delirium is very disturbing to people who've ever experienced it. And if you've ever talked with people who have some awareness that they have had a component of delirium, they will describe to you how frightful it actually was. So in addition to at the person level, that adverse consequence, we know that this has other adverse consequences, including it tends to keep people in the hospital longer. People are, again, more likely to not discharge back to where they were living, but to a nursing home instead from a hospital stay if they develop delirium. Seems like it makes a person more likely, maybe it's just a marker for death within the next 12 months. It also seems, new research seems to suggest that there's kind of this relationship with predicting or predisposing somebody to cognitive impairment or dementia. And delirium can be persistent for quite a long period of time, up to 12 months after discharge. And so it can be subtle, but it's often, once it's established, it's very difficult to treat, and it's quite persistent. How can we detect delirium? The confusion assessment method that was developed by Dr. Inouye and colleagues is very frequently used and well-studied, well-validated instrument for detecting delirium. It's got good test properties. There's also a version that is used in the ICU called simply the CAM ICU. And Dr. Inouye has been a leader in the study of delirium, and this landmark, again, classic now study on delirium prevention, published in the New England Journal, showed that prevention was more effective than treatment, and that's the bottom line here. And again, a recurrent theme across all these conditions. As I said in the beginning, that ounce of prevention is worth a pound of cure. Prevention is more effective. We have very little that we can do except provide supportive care to an older adult who develops delirium. And so this approach for prevention, called the Hospital Elder Life Program, or HELP, initially studied and described in this journal article, has been spread across institutions, replicated, and I would say has probably not infiltrated most institutions at this point, but it is important intervention to be aware of, and I would suggest advocating for this at your institution or features of it. The focus was identifying things that might be contributing to delirium in an intervention in an individual and intervening on those, and with these particular domains of cognition or orientation, sleep deprivation, immobility, sensory impairments, and dehydration. So in other words, things to promote sleep if the person were not sleeping well, making sure that if the person were not taking in fluids, that they were administered fluids, etc. This approach, looking for factors that contribute to precipitation of delirium and trying to treat those expectantly, was found to reduce the number and duration of delirium episodes. Lastly, we'll talk a bit about falls in the hospital. What do we mean by a fall, or how do bodies that regulate hospitals define a fall? This is the definition: any unplanned descent to the floor. This is a little different than in the outpatient setting. This in the sense that acute events that can lead to a fall, such as a stroke or passing out, i.e. syncope or a seizure, those events are still counted if they result in a fall, if you're counting falls and tracking them in the hospital setting. Falls are the most common accident that happen in the hospital, and unfortunately, a goodly number of them result in an injury, and sometimes those injuries can be serious. Sometimes those injuries result in death. I describe a case of a patient who fell in an ICU, developed a head bleed, and within 4 hours had died from that head bleed. You would wonder, how can somebody fall in an ICU when they're so closely monitored? But people do. And falls, if they don't result in death or serious injury, tend to lengthen stay and increase costs. The Centers for Medicare and Cascade services, or CMS, in recent years have looked at conditions that develop in the hospital and determine whether or not those conditions are things that should happen in hospitals, and falls happens to be one of the conditions that they think should not happen. And so they have been deemed what's called never events. This is an evolving area, but at this point in time, hospitals are no longer reimbursed for any care that they have to provide to a person who falls on their watch. So, for example, if a person who falls in the hospital breaks their hip, they need surgery, then the cost of all that downstream care, the hospital cannot charge the insurer, i.e. Medicare, for and get reimbursed. The hospital has to cover those costs. Falls are also a very common cause of lawsuits and successfully fought lawsuits. In other words, payouts are frequent, and they're often in the order of millions of dollars. For these reasons, reducing falls in the inpatient setting is a national patient safety goal. And you can see the target here. This is a rate, so 2 to 3 per 1,000 patient days is the rate that most hospitals are trying to achieve. Where do falls occur and when do they happen in the hospital? This is just a bit of descriptive, just to kind of crystallize some ideas about this in your mind. It's kind of an understanding. Typically, most falls are unwitnessed, although not all. So some falls may occur or even be what are called assisted. They occur in the process of a person doing something that we want them to do. For example, working with a therapist on their mobility. About 50, maybe a little bit more % of the time, falls will occur out of bed or chair or during transfers between the two. A number of falls occur in bathrooms. And people have looked, but there doesn't really seem to be any relationship to time of day in terms of when. So they happen all the time, essentially. And falls in the hospital occur similar to delirium for a variety of reasons. So we call these risk factors. A hallmark of care of older adults is what we call geriatric syndromes. And syndromes are things that are usually due to multiple factors rather than a single cause. This slide illustrates what some of the key factors are that contribute to falls in the hospital. So in addition to age, looking down on that list of what we call intrinsic factors or within-person factors, incontinence, urinary incontinence, toileting urges in general are a risk factor. Confusion. So you can see that there's an interrelationship between some of the complications, meaning confusion, acute confusion due to delirium, potentially. So if new delirium has developed, that person's at high risk of falls. People who have confusion for other reasons, so they may have a memory disorder, they may have dementia. Those people are typically at much higher risk for a fall. And importantly, ever having had a fall in the hospital. So if you know when you're doing an initial assessment that, or you ask and you find out that a person has been in the hospital ever and fallen, that's an important thing to document because it tells you right away at that point, even if they don't have any of these other issues going on, that they're high risk for having another fall during the hospital stay. What about extrinsic factors, meaning things that are in the environment or things we do to people? So medications, a lot of times we're adjusting medications. We may be giving people medications to treat symptoms. For example, a common thing is somebody has pain, they're lying in bed, they get one of those muscle relaxants, like I showed you, that have the anticholinergic side effects. They then get confused, they then fall. These medicines can also oftentimes contribute to dizziness. So oftentimes we're titrating up on the medical service. We may be titrating up on people's blood pressure medicines. That may make people feel lightheaded or dizzy. So the treatments that we're doing, oftentimes, all the time, I would say in good faith, many times with good, justification, we have to monitor people to see if they're having adverse side effects. Some medications we want to avoid entirely. Other studies have shown that this up with assist order, meaning somebody's worried the person isn't safe to mobilize, that's what this is a marker of. So they have some mobility concerns. And then some studies have shown that the ratio of nursing to patients is a factor in falls. What about risks for injury? So the thing we really worry about with a fall is that the person is going to sustain a serious, if not life-threatening injury. So any injury in this study, meaning across the spectrum of severity. They might have had a minor injury like a cut or a severe injury like a fracture. Age, so again, increased age, falling in the bathroom or outside of the room, or a fall that was not assisted were risk factors for any type of injury. And then this is a mnemonic for serious injury. And more we're targeting in preventive strategies not only the actual factors that lead to a fall, but these other factors that are what we call risk factors for harm or injury, the ABCs. So again, age, recurrent theme, the oldest old. People with bone disease, so any kind of metabolic bone disease from Paget's to osteoporosis. Coagulation, so they're on a medication that thins their blood, or S is recent surgery. Probably due to the combination of factors. They've had drugs that are used for anesthesia, they may be on new pain meds, etc. Can we predict who's going to fall in the hospital? There have been a number of tools that have been developed, again, structured assessment tools or instruments to try to get at and identify who's more likely to fall. It's important to distinguish these from what we call risk factor checklists, where people would be identifying what is this person's risk factors. These are just predictive scores. They result in a score that says, if you're above this score, yes, you're at high risk for falls. If you're not, then you're not at high risk. The upshot of all these tools, and depending on which hospital you go to, different tools will be being used, is that they have limited utility. So we see lots of people who fall who, by any of these measures, would not be predicted to fall. And one study, in fact, showed that clinical judgment on the part of the nurse was as good as one of these structured assessments. So a real opportunity here for, again, interdisciplinary team input. If you have any experience in working with hospitalized older adults, you focus on function, you observe mobility, you can contribute to helping a team understand, I think this person is high risk for falling in the hospital, and speaking up about that, because it's really needs to be a team approach in raising awareness of this. And fortunately, it looks, based on some limited amount of data, I would say, that trying to, similar to how Inoue in her delirium prevention protocol targeted risk factors at the individual level, it looks like trying to target individual or patient-specific risk factors for falling is an effective approach to reducing the chances that a person will fall in the hospital. This is a meta-analysis of studies, not a large number of trials, but adding to this a recent trial that was done and published subsequent to this meta-analysis. Again, a similar result. And especially key was in that most recent study, looking at people who were both older and younger. This was effective in the older adult population, this approach to individualized assessment or patient-specific risk factor. So the multifactorial just refers to that. Assess each individual for things that may be a contributor to his or her falling and address those risk factors. Unlike that individualized multifactorial risk factor approach, people are also looking at, are there any single interventions? Because if there's something singly that you can do that's simple, that's effective, great. The next few slides are going to summarize a range of those single interventions as being so far shown to be either based on research ineffective, effective in reducing falls, or the evidence is at this point insufficient and we need further study. So again, a range of things. So physical environment. Traditionally in the hospital, the focus on fall prevention has been on how can we modify the environment. So in recent years, this more sort of patient-oriented or patient-directed, individualized or tailored approach is becoming better studied and better understood. But the bed rails, the physical restraints, the chair and bed alarms, those are examples of environmental interventions. Low beds. Really, it doesn't look like there's a lot promising here so far. Education and HP is health professional follow-up. That looks like that works for cognitively intact individuals. Other single interventions here: increasing observation by volunteers, insufficient evidence. Hourly rounding, this is a phenomenon where patients are checked on frequently, asked about any needs they have, whether they need something to drink, do they need to get up to go to the restroom. Hourly rounding, again, insufficient evidence at this point. Medication review and adjustment, interestingly, effective. So as a single intervention, so this is important in the sense, I think, that medications really have a huge role to play in risk, contributing to risk, and so anything we can do to address that risk may matter. At this point, delirium prevention has insufficient evidence, although it's such a strong predictor for lots of other adverse outcomes. We have good reason to focus on delirium prevention just to prevent delirium itself. And again, a whole host of other things being looked at with evidence not sufficient so far. Promoting continence, education of family or staff, managing dizziness, drops in blood pressure when people stand, insufficient evidence, modifying footwear, correcting visual impairment, all of these yet not shown to work to prevent in-hospital falling. And I alluded to this a minute or two ago, but I would like to put forth the idea that there's really, at this point, as there should be, a paradigm shift, where if you are a hospital provider, being part of the thinking and the initial assessment and evaluation of a person's risk for falling, if they're in the hospital and they're very elderly, everybody has a role to play. The old paradigm was this is really in the purview of nursing. Nurses dealt with this, and it was environmental modification entirely. At this point, we know that it shouldn't be the burden of nurses, and that there's more to it than the environment, that this is a complex problem that everybody is responsible for having a role in, and that it's really important to communicate your concerns to the team, and that rather than just worry, there are things that we can do, and the focus, as part of recent evidence shows or suggests, needs to be on addressing patient-specific risk factors. And as a physician myself, I also strongly believe that there's a responsibility of physicians here. And in part, just because we write orders, and there are some things that only we can change as a result of that. Changes to medications, changes to things that tether people to their bed, like catheters and IVs. So we need to be part of the process of preventing falls. And I think this study by Cumming is evidence that we have to be part of it, because some of the things that we can do or accomplish are critical in that overall risk reduction process. So physicians really need to get on board with this in the 21st century. Just to touch on these own clinical judgment, and also look at risk factors for injury or harm, because those may be a group of people we want to be especially focused on when we are pressed and we need to decide who do we need to focus on most and first. That those modifiable patient-specific risk factors should be identified for all patients, and that staff education is important, but probably certainly not sufficient, and that the team approach is really important in trying to reduce risk ultimately. So just to sum up across these conditions that I've talked with you about today, that we see hospital-related complications much more commonly, again, in the oldest old, but also in people who have functional impairments premorbidly. So assessing people for those functional impairments is definitely worth our time, and having an understanding of people's premorbid functioning. And as you've seen, there's good evidence that many times we can prevent these complications from happening, but we have to have a high index of suspicion, and we need to be proactive in order to do so. So that's it. Yeah. Tell her this. She's got it open.
For their care, particularly older patients. I mean, you spoke really, really well about the whole thing, but that 92-year-old lady could have avoided a lot of this if her doctor, if she'd made a call to the doctor and said, "Where should I go?"
Mm-hmm.
Do you want to repeat the question?
Yeah, so don't we need to be educating our patients about these issues? I actually think a lot of patients' families are pretty aware of risks. Although I say that, and I think of two good examples, and both of the families are, the family members who have that awareness are nurses. So it's a tough one. I mean, I think people still need to have confidence that they're going to be able to receive appropriate medical care wherever they go, even if it's an ER, even if it's a hospital. I think empowering patients to actually, and families to actually be a little bit more comfortable being assertive in saying, well, and many patients' families are, but not all, that, well, do we really need to do this? Because there is in addition to a tradition of deference oftentimes to physicians, certainly stronger depending on what cultural background you may be from, and certainly age-driven at this point in our current population of elderly. There's things move so quickly that if somebody doesn't stop that sort of, that cascade, it's not only a cascade of complications, it's a cascade of evaluation, as you saw in the emergency room. I think more and more work needs to be done to educate providers at that kind of point of care, initial point of care. So not that there haven't been interventions that have been tried in the emergency room, but I think we still need more work in that area.
Isn't part of this maybe sort of a culture of excessive care for the elderly and excessive care in hospitals versus, maybe some people, the family needs to be encouraged, and people need to be encouraged to take a more of a face death approach.
Mm-hmm. Yeah, so the question is, isn't this just a symptom of excessive care? And should we be being more proactive, I think is also part of your question, in deciding that maybe that, life has to end at some point.
That's basically it.
Yeah. I think for better or for worse, just what happens when people show up in emergency rooms because of liability. There's also, in our country, there's a huge liability concern. And so depending on where you practice, the kind of assessment that happens will vary considerably. So if you're seeing this person in an emergency room as opposed to in a, say, hospital at home type of setting where the person has decided they don't want to be hospitalized, they want to actually get all their care at home, or if they're in a skilled nursing facility, or they're in a clinic when they present with this set of symptoms, the approach will be very different. And certainly in an emergency room, the tendency is aggressive care, aggressive evaluation, and that's true for all comers. So I think the key thing is trying to further individualize approach to care and involving families, even in that moment of urgency. To put a person, there were a number of tests run on the patient when she presented, the case patient when she presented to the emergency room, and she's actually a real patient. She was a real patient. I didn't devise that case. I don't think I could have. But there is time elapsed. There are decisions made. And I think the key thing is, in an older person like that, making sure that that sort of impetus to we're in an emergency room and we have to get things done, that sort of speed, that kind of impetus can be tempered by spending the time to engage the family, if the person comes in with family available. The other thing is really important, is documentation of wishes. Unfortunately, or fortunately, again, oftentimes research has shown that people change their minds in the moment. They may say they don't want aggressive care, but in the moment when they feel really bad and they can't breathe, they want aggressive care. So some of it is hard to lay out in advance in terms of kind of setting things in stone about how we're going to approach this person if they show up. So I think your question is very complicated.
No, it's definitely complicated. I don't want to monopolize the conversation, but just coincidentally, I work at the federal jail.
Uh-huh.
We've got a 60-year-old, a 70-year-old, and a 75-year-old in the hospital. They've been there for roughly 3, 4, and 5 weeks. And the longer they're there, the more stuff they're finding. And these guys are both, all three of them, they're elderly, even if maybe not by age.
Sure.
They've had hard lives and they're elderly. So it's just interesting. I've never seen anything like it. But, it goes on and on. And they finally got a couple of them transferred to skilled nursing facilities. But it's just coincidentally, it just happens at the same time. And I'm not saying they didn't need the care, but once they were in the hospital, they started finding more and more stuff, and it just went on and on.
Or is it more and more complications happening? That's the other thing.
Well, a little both. But
yeah.
I mean, it's a little bit what you're saying. You find one thing, they get an infection on this, and we go to another test, they find something else.
Right. The longer you stay, the longer you stay applies. But I think the other thing, and some of this talk, I tried to, this used to be a much longer talk, and I had discharge. I think I had that as a hazard, maybe I took it off the hazards of hospitalization, but hospital discharge. I think once people get in the hospital who are elderly, there's a lack of comfort in discharging them, meaning that people aren't quite sure what to do with them or where to send them. And there's a big fear about sending them home. And so again, these patients who I guess would presumably, I don't know, they should go, they sound like they could have gone back to jail, so they had an automatic dispo.
They can't go back to jail because they can't take care of themselves.
Do the care there
that's
yet.
Part of it.
Okay.
But I like I said, I don't want to monopolize what you're talking about, but just coincidentally, this is happening. And like I said, the hospitalization just seems to go on, and I think it's partly, I mean, you can't deny these guys care. It's different than the family saying, well, we don't want to have that. They wouldn't have wanted that. But nonetheless, in the hospital culture in this country, things can just get really complicated and very complicated tests. And if you don't, as you said, the wishes aren't stated in advance. Some of that test, like that, the
default is to do everything here. Yeah. No, that's really true.
So Homer is wondering if you could explain a little bit more about the CAM tool.
The CAM tool. So the CAM tool is a fairly straightforward in-person, it's a combination of, it's essentially observation of features of delirium, and you say whether or not they're present or absent, and you come up with a score that tells you delirium is present or delirium is not present. Is that enough? That you can actually, if you Google, the CAM is so widely published on and used that if you Google delirium and confusion assessment method, you can get a copy of it. There's actually even, I think, freely downloadable the protocol, the instructions for how to administer the CAM. It's just a tool. Once you become familiar with if you see enough delirium, our geriatric medicine fellows and psychiatry fellows, for example, it's kind of becomes pattern recognition. You don't need the CAM, but the CAM is very useful when you're learning to remind yourself what are the features of delirium and am I observing them in this patient.
So Homer is wondering, Missoula is wondering why don't some of the single interventions such as bed rails, restraints, low beds, aren't these physical items effective in avoiding falls, I guess?
Why are they not effective? I think because falls happen for, again, kind of going back to the concept that falls happen for a variety of reasons. And similar to studies that have looked at falls in the outpatient setting, because they're a complex problem, they require complex solutions is the simplest way to think about it. That a sort of single approach addressing only some issues and not all that might be contributing issues to that fall occurring are probably, the dose of that is just not enough. It's not addressing enough of the risk profile. And in fact, some studies have actually shown that using some of these may make people more at risk for injury, falls. Early studies of bed rails, for example, people had become strangled and caught in bed rails, like between the bed and a bed rail, and died, from suffocation, entrapment, etc. So not only are they not effective, but in some instances they have risks, real risks.
So Ketchikan wonders if a person falls while in the hospital, who then pays the bill if Medicare and Medicaid don't cover fall-related injuries?
So the hospital pays those charges. the hospital basically eats those. That's free care, essentially free care.
And Homer wonders, do you think hip protectors should be given out for patients with who are at high risk for falls?
Hip protectors haven't been shown to be effective in reducing injuries from falls in outpatients, and I'm not aware of any studies of hospital patients per se, so I think the jury is out on that. They've been studied also in nursing home settings, so it really is very setting dependent potentially, so there might be some benefit, but I don't know of any studies showing a benefit at this point.
Missoula wonders, how do you work with independent patients, those who used to be very active, to understand and accept that it may be good to accept walking assistance for their safety, at least during recovery?
So read the question again. How do you work with
Independent patients who used to be very active, to get them to understand and accept that it may be good to accept walking assistance, at least for their during the early part of their recovery, for their safety?
You know, I don't think there's any magic or right answer for that, but my thoughts kind of are going towards sort of educating those patients, assuming they're able to, I think it's assumed in the question that they're getting up, trying to be active when in fact they might be at risk in a way that they weren't before for hurting themselves or falling at least. Really, I think educating them about the things that you as the provider are worried about and understand that they may not understand about how some of their new impairments and or medications, devices that are restricting their mobility, any of the above, might lead them to have a fall, and humor you for the present. And it's better to err on the side of safety and caution and having somebody walk well assisted for that short-term period of time. And there's probably that post-surgical risk factor is really truly around just the kind of the person's not back to homeostasis yet. They're not back to where they normally are. And they may not realize that until they get up and move, or they may not be aware of it because of effects of medications that are being used to treat for example, their post-op pain. So,
so I guess this is just a comment, but maybe you have a follow-up to it. This person says she's seen a lot of no follow-up care after elders were discharged from the hospital, not from any agencies, to make sure that the elder is doing okay at home. So I think this brings up the issue that you'd mentioned about discharge being a particularly precarious time.
Yeah, risky. That appears to be changing. I know our hospital is now doing follow-up calls, post-discharge follow-up calls within 2 days to ask patients if they understand their treatments, did they pick up their medications, do they know when their follow-up appointment is. So kind of a bridging type of call. And I think that there is going to be increasing spread of the care transitions, which is much more intensive than that. But the care transitions, for people who may or may not be familiar with that or have heard the term, it's essentially post-discharge follow-up care, usually delivered by nurses who start meeting with the patient and or patient's family prior to discharge, counsel, go over medication lists, counsel about the chronic conditions and the new treatments that might be, or treatments that might be changed, that a person's going to have to understand when they go home, and then follow up thereafter, typically in the home for a period of time. It depends on where you're practicing, but understanding that there is an intervention out there and that outreach does need to occur, yes, I think that's it's a very important observation if that isn't happening. For example, people who are discharged after treatment for a injury, like they've they're recovering, an elderly woman oftentimes will get admitted for a hip fracture. We know that people discharge from hospital after a hip fracture are at high risk for another fracture in that window of time after discharge. So certainly more attention to that area is
The
appropriate.
problem is a lot of that kind of good, that follow-up care is not reimbursable, you know.
And you need to repeat that.
Yeah, so the comment is that some of that kind of care is not reimbursable. Hospitals may be at risk. There may be some liability for complications that will come to rest on hospitals who don't provide that. So that may be a driver. But the care transition intervention is, I mean, it will eventually, I believe, be a reimbursable service.
Any other questions here? You've got a lot of thank you and thanks here.
Okay.
Thank you.